I am Dominic Tarpey. I'm a member of the committee that organizes these grand rounds. So welcome everyone to today's intensive services grand rounds here in the Department of Psychiatry and Behavioral Sciences at UCSF. And I think probably everyone's pretty familiar with the usual Zoom housekeeping. We'll use chat primarily. There'll be some breakout rooms as well. But so if you have questions, send them via the chat if you don't mind. Otherwise, stay on mute. Our topic today is on ethics in psychiatry, particularly ethics consultations and ethics committee work in hospitals. And our two presenters are Dr. Sirisha Narayana, who is chair of the Medical Ethics Committee at UCSF. She's also assistant clinical professor of medicine at UCSF, director of education in the Division of Hospital Medicine, and did her training at Northwestern University and residency at University of Washington. And then our other presenter is Dr. Tammy Duong, who is a member of the UCSF Ethics Committee, and Dr. Duong is assistant clinical professor at UCSF Department of Psychiatry and Behavioral Sciences. She's also in the role of Associate Program Director of the Residency Training Program in the Department of Psychiatry and Behavioral Sciences and Interim Associate Medical Director of the Adult Outpatient General Psychiatry Clinics. She did her training at the University of Kansas and residency at the University of Southern California, and also completed a geriatric psychiatry fellowship here at UCSF. So we're very fortunate to have both of them here to present, and with no further ado, I will turn it over to them. Thank you.
Hi, everyone. Can everyone hear me okay? Just popped in my headphones. Okay. Well, it's so nice to virtually engage with all of you. I'm Sirisha Narayana. I'm the chair of the ethics committee at UCSF, and I work with Dr. Duong on that committee. And it's an honor to be here. This session is going to be largely interactive with a very, very small didactic component. And so for that reason, and there will be breakout rooms as well, I encourage you, if you feel comfortable, to turn your video on so we can all participate in this conversation, only if you feel comfortable, of course. So thanks again for your attention. I think I'm just going to start by sharing my screen here. All right, and as I told the others, my presenter mode does not work, so you're going to be seeing a lot of random notes at the bottom of my PowerPoint slides. But just so we wanted to speak with you today about ethics as it comes to consultation in psychiatry, but also the ethics committee and some various nuances, what you need to know, what your patient or your family members may need to know as well. I have nothing to disclose. Tammy, it looks like you have nothing to disclose either. So we both are here to primarily talk to you. What I'd like for you to come out of this talk with is an option for a framework when thinking about complex ethical cases in the hospital, and some nitty-gritty about how and when to call an ethics consult, and familiarize yourself with the concepts of moral distress and moral residue. And of course, we have a psychiatry twist to this based off the cases that we'll be going through in our discussion. So I'm just going to start by giving you a little bit of background as to how we think about ethics the way we do, and then we'll go on to the case discussion. So this slide, I'm actually probably working on tweaking at some point in this year. You see a lot of pictures of primarily old white men that have guided a lot of how we have established various moral theories that have proved important in the medical world. So normally if we were all in person, we'd do this, like inadvertent pop quiz where we'd guess the name of these various philosophers. I'm just going to go through it for ease of discussion. So this man here is Aristotle, and Aristotle, a big principle of Aristotle was the idea of virtue, that a central task of morality is not necessarily about the principles or knowing or applying them, but really just about being a good person and possessing these virtues that define what we call moral excellence. And I bring this up because this is a big foundation of the Western ideal of what morality goes into our role as physicians and clinicians as it comes to patient care. And this next person here is Immanuel Kant. Kant really defined this concept of duty and categorical imperative. So a classic example is a friend is drowning. Well, your responsibility is to try to save that friend, not because you really care whether they live or die, sadly, but because your duty is to be this person's friend. And this plays in a lot as to how we consider duty and our responsibility as clinicians when caring for our patients. These two folks here, so in the top is John Stuart Mill, in the bottom, Jeremy Bentham. John Stuart Mill really characterized this idea of utilitarianism that's come up a lot, especially in our COVID times, and this idea of greatest good for the greatest number of people. And things like public health ethics really often relies on utilitarianism as a concept. And Jeremy Bentham suggested that what was greatest utility is what is of greatest pleasure. Others may contest whether that's truly pleasure, that's utility or not, but really it's just what the greatest good is. And then here, this woman is Carol Gilligan, who described this idea of like how we determine morality or how we experience morality as a phased response, that when you're much younger, like a child, it's very egocentric and very self-oriented. And as we evolve into adulthood, it matures to a balance between what's good for self versus what's good for the general populace. So why does all this matter? I mean, definitely we're not going to be, when we engage clinically, we're not necessarily invoking a lot of these philosophers, but their ideas really set the foundation for these 4 principles of medical ethics, which many of you may be familiar with. This idea of beneficence, so what is good or how you are not, non-maleficence is how you are not harming someone, for lack of a better description. Autonomy, which was originally described as respect for persons, so what an individual may desire or wish for themselves or what their individual values are, and we have termed that as autonomy. And I will say that autonomy has evolved over time, especially now, and especially in this country with this, with greater emphasis on individual rights and the role that that should play in determining what care we do and don't offer, for example. And then justice. And justice I find to be a very, sometimes can be difficult to define. You can think of justice as fairness. Yes, is one person given the same options and opportunities as another? You can think of it from a societal standpoint. So like rationing scarce resources comes into play here. And justice in and of itself has a contextual factor as well as to how we actually make decisions for our patients moving forward. So when it comes to actually answering a clinical dilemma at the bedside as it comes to an individual patient case, there are various different models that have come up. And one that's pretty popular is this idea of the 4 boxes method, which was defined by folks at the University of Washington and University of Chicago. And what they did was they created 4 quadrants: 1, medical indications, patient preferences, quality of life, and contextual factors. And some of this is in the handout that you have. That's I believe attached to the calendar invite also. And what this did was try to put the 4 principles, which you can see on the slide here, into other more practically applied terms to help us think about how these different principles are applied. So, for example, medical indications is really about beneficence or non-maleficence. So is it, if you take an ethical question of, is it appropriate to perform this surgery on a patient who doesn't have capacity? Well, what are the medical indications for that surgery? Is it a life or death circumstance? What are the harms, etc.? Those are all concepts that go into here. And really it's rooted in this idea of, are we doing more good than we are harm? Patient preferences is autonomy. So what would the patient have wanted for themselves? Like, have they articulated a preference in the past? What do their surrogates say? Do they have capacity? Those are all questions that go into autonomy. Then quality of life, and is somewhat controversial, I would say, but we use that term to think about what does this person's life look like, and how that has a direct interplay with the patient's preferences, of course, but it takes into consideration all 3 of these big principles of beneficence, non-maleficence, and autonomy. And then justice is its own box. And if we go back to this slide, we call it contextual factors. And so, like I said, this could be issue of resource limitations. Are there any other issues at play? Biases that we as clinicians may have. financial constraints. These are all contextual factors that frame this idea of, are we actually fair and equitable? So you might ask, well, how do you decide which box wins out? How do you say, okay, well, the patient's preference is this, but that's directly contradictory to what the medical indications may be? Well, the truth is, you can't really weigh the boxes. It really just depends on each scenario. And it's about the moral relevance of the facts that are within each of these boxes. And it comes not from the principle itself. It's not that autonomy always weighs out compared to beneficence, or justice always weighs out compared to non-maleficence. It's really about each individual case example. And this is just a framework to help guide discussion for everyone to come to a conclusion. And ultimately, how do factual circumstances meet the goal of the principles that may be relevant to each of the boxes? So I'll pass it on to Tammy. And Tammy, I'm sorry the animation won't work on this slide.
Okay, there's no animation. There's no animation going on.
Okay, great.
Yeah, thanks, Sirisha. Yeah, really to kind of take what Sirisha says, and then what I wanted to do in this slide to take a moment to really talk about apply it to some of these ethical issues that we often see in psychiatry, and just take a moment to think about and reflect on some of these things that we do pretty routinely in psychiatry are actually guided and rooted in a lot of these ethical principles. And so just to take a moment to think about that. And these are principles that probably happen in all specialties of medicine, but I think in psychiatry, we're a little bit more explicit in the tension that we feel when these principles collide and we have to think about which one we want to weigh versus the other one. So the first one I wanted to talk about, and we think about this all the time in our practice, is about confidentiality and privacy. And we can think about this in terms of patient autonomy and what the patient prefers, because a lot of our patients, as you know, are really concerned about confidentiality and privacy. You know, they tell us these things that they don't tell anyone else. They tell us about their relationships, their work, about prior traumas, you know, and sometimes that these patients end up being our colleagues, and it adds another complicating factor sometimes. And so what we end up doing to really protect their autonomy and their privacy, sometimes we deliberately maybe write more vague notes in the chart that we normally would be, or we may keep separate psychotherapy or process notes that aren't a part of the official medical record. So we do these things to sort of to readjust for this. But then at the same time, there are times where we go and we're very conscientious about breaking that same confidence and that same trust that we establish with patients, right? And we sometimes do this and favor other ethical principles at the same time. A good example of this is something we do all the time. If a patient is at risk for imminently harming someone else, or they disclose a crime to us, and then we sort of violate their personal autonomy in the favors of the principles of justice and non-maleficence, right? In order to fulfill our duty to warn and duty to protect, that protect other patients at the same time. So you can see where these principles come directly into contrast with each other sometimes. And then based on these contextual factors that Sirisha brought out, we have to weigh in like which ones are we going to follow at that moment. Another good example is when we have this all the time, patients who are acutely suicidal or can't take care of themselves because they're really ill. And again, we violate their autonomy. We do this in favor of beneficence and not on malfeasance. And sometimes we go into this role called parens patriae, which means the state as the parent, right? That we have decided that we know what's best for this patient at this time because they're so sick. And as psychiatrists, you know, we're often put in that place where we then go to a lot of measures to fulfill these ethical principles, right? We petition the courts, we put patients on hold, we essentially take away their rights and their autonomy to be able to fulfill this. And then I just wanted to spend a second talking about, you know, boundaries and maintaining clear roles in psychiatry, because we talk about this in our specialty all the time. And I wanted to take a second to look at through an ethical lens of why this is so important, other than, you know, treating patients and that's going to be what's helpful for them, is that sometimes when we don't follow that rules of boundaries and clear rules, we're not actually acting in ethical principles. And just to bring us back up to speed and point of reference, I wanted to remind us that a boundary crossing is a deviation for a defined role of the provider and the patient, but that's usually harmless and non-exploitive in nature, and sometimes it can be even therapeutic, versus a boundary crossing, which is an exploitation between the patient and provider, or when the needs of the provider come before the patient. And so you can almost imagine, sometimes we do this really inadvertently. Sometimes we get a lot of pressure to, give patients, that extra appointments or that after hours appointment that we wouldn't normally be giving other patients. And I see this all the time, that patients put a lot of pressures on us sometimes to prescribe medications we don't really think are indicated, right? And I don't know how many times I have thought, and maybe you have thought too, there's that little voice inside of my head go, wouldn't it just be a little bit easier if I just went ahead and, provided that prescription of Xanax, even though I knew on the other hand, it wasn't in the best interest of the patient. And why that becomes a slippery slope, and to think about that, that's actually really then fulfilling the provider's interest of not wanting to, meet conflict and, create tension between the patient versus actually acting ethically for that patient in that moment. And then the last thing I wanted to bring up is that concept of informed consent. And I bring this up because, we see this all the time in psychiatry. And I mentioned earlier, sometimes we're very conscientious about violating patients' autonomy. But at the same rate, in psychiatry, we often go to great lengths to protect patient autonomy. And California in particular leans very heavily into patients' rights and patients' autonomy. And a good example of this is, when I worked in LA County in the inpatient, before we gave anyone psychotropic medications, we actually had to go sit down and do, formally see if they had capacity, and they had to sign before we could even dispense psychotropic medications. Another good example is with electroconvulsive therapy, or ECT, where you need 2 board-certified psychiatrists to say, yes, this procedure is indicated and appropriate for this patient. And if you do some parallels to, our cousins in medicine or surgery, I don't think it's the same level and standard of getting, everyone to sign off for antibiotics, or even there are a lot of procedures that are probably more invasive than ECT. But I think we do this in psychiatry because, we're really conscientious about these ethical principles, and we really try to guide our behavior for it. And it also speaks to just how vulnerable our patients can be and how susceptible they are to kind of falling in between these boxes, or when things come to tension between these ethical principles.
The question arises as to, well, when do you call ethics, and when do you actually need a broader group of people to talk through some of these issues? I'll forewarn the group that there may be folks here who do not primarily work at UCSF Medical Center, Mount Zion, or Mission Bay, or trainees who may rotate around different sites. So the next several slides are unique to UCSF Health, and by UCSF Health, I mean the Med Center, Mount Zion, and Mission Bay. But really, the idea here is, like, when there are complex conundrums related to an ethical underpinning, it is always appropriate to call ethics. And when in doubt, it is always okay to call ethics. Now, sometimes there is issues of policy clarification or legal issues, in which case there's always a question that comes up, well, do we call you? Do we call risk management? And sometimes there is some natural overlap. And at least at UCSF, and I assume the same is true at the VA in general, there is direct lines of communication that we can help you through those questions. So just as for those calling an ethics consult at UCSF, the system we have to call it is admittedly a little archaic, but that's the system we have in place. And that's actually, you call the operator, you push 0, you ask who is on the ethics consult pager, and then you page that person. And it's one of 3 people, Andy Josephson, Wade Smith, both of whom are neurologists, and myself. And the direct page to one of us, we cover a pager 24/7 all the time. You can always access us. And many things can be quickly discussed over the phone. For those issues that require a little bit more time, a little bit more deliberation, we will then ask members of our committee to come together to help navigate these challenging issues at a time that's convenient for the care team. We ask that the calls come from the primary attending. Although anyone can call a consult, you do not have to be an MD only to call a consult. And we accept consults from patients themselves. Patients also may go through the operator to request to speak with us. And again, a nuance here at UCSF, if you're trying to call a neurologist, they're not in CareWeb, you have to use PagerBox. So I just wanted to let you know about that. And then I did want to spend just 1 minute on this idea of moral distress, because clearly this comes up in many of these complex issues. But this idea is that both people believe they know the ethically appropriate course of action, but there are various obstacles that limit carrying out that course of action, whether it's the lack of time, whether it is power dynamics, whether institutional policy, whether it's a hierarchy that comes into play. But it basically feels like your morals and your ethics are being challenged because you're unable to change what is happening. There are different aspects to this. There's this idea of moral residue, that every time you experience this as a provider, a clinician, a frontline worker, that you hit a mark of moral distress, and then when you come back, you have what's known as residue. And this is brought up in the context of why it is that our jobs are so hard at times, and why there are issues of burnout and challenges with resilience, is because many of these issues cause a lot of distress.